My name is Ronan Fox, as so well introduced, and I'm here to talk to you today about technology and how technology innovation can assist in building site partnerships. But before I get into the meat of the presentation itself, it's worth probably introducing myself because it's my first time here, so I would say I'm a newbie. So my career really has been focused on software and technology and ways that technology can have a positive, meaningful impact on societal issues. So that really has driven a lot of the focus, I suppose, over the complete career, but has brought me through a range of environments within which technology is used, and that's in multinational, high-tech, blue chip, you've heard all those terms before, startups and academia, and most recently, obviously into ICON as a clinical research organisation. So what has happened really over that period of a career is that we've had many technological revolutions. We've had the birth of the internet, we've had the birth of AI, the death of AI, and the rebirth of AI. We've had the involvement of the semantic web, which is like Web 3.0. We've had object-oriented design, we've had client-server technologies. They all add up. But ultimately, all of that, from my perspective, has been how can I use that in a way that enables people to collaborate, integrate, and work across data sets and domains that are heterogeneous, that are not the same. You have people at various points in the bench to bedside development process speaking different languages. And I'm not just talking about French and German. I'm talking about the domains within which people work, from life sciences through to clinical research and into clinical practice, and then as we close the loop backwards into life sciences. So when I joined ICON about 7.5 years ago, I joined a group called Firecrest, and Firecrest is a technology, I suppose, provider for ICON that enables site interaction. So it's a kind of a site-focused technology group. And as I moved through ICON, and I learned more about the clinical research specific arena within ICON, I brought technology, obviously from background, best practice, organizational design, and so on, into the wider ICON IT environment. So why is that important? You might think, well, what has that got to do with technology? Technology is not an island. Technology only succeeds when you have people and processes aligned with technology. Otherwise, technology is a shiny bauble sitting on a shelf that's useful for nothing. So my focus has been around how do you bring people on the journey, how do you bring the processes in alignment and have the technology as an enabler for the processes that you want to enact. So to push on, what are the industry challenges? And these are obvious, and they're obvious probably to people in this room more than even to me. But I think it's worth just setting the stage in terms of why bother. We know that from 3 different research groups, international research groups, have looked at the main reasons for the challenges that exist in the industry around timelines, recruitment, data quality, and timeliness of data quality. Lack of support is one of the top reasons that people leave their jobs in sites. Budget and contract negotiations are amongst the top 3 areas for improvement. And this is almost related directly to the next point, which is we've had a massive increase in protocol procedures to be done per protocol over the last 10, 12 years. That protocol complexity drives all sorts of other challenges, I just mentioned them a little while ago. A lot of trials fail to meet planned enrollment criteria or in terms of timelines. And 30% of sites fail to enroll a single patient. So you're talking about site partnerships and site engagement. It's very hard to engage with the site or partner with the site when the site is the wrong site on a particular trial. So from our perspective, that is a massive potential for improvement, but also massive current wastage in the industry. Sites need support to conduct clinical research. They need support from other sites, they need support from sponsors, they need support from other stakeholders who have experience in particular therapeutic areas, etc. Protocol complexity is driving cost and timelines. Number of procedures increasing, number of clinical endpoints increasing for every trial we do. And patient recruitment is challenging, and particularly as we get into personalised medicine, orphan and rare diseases, it becomes even more challenging. And that's where diversity and inclusion becomes a massive potential impact and source, I suppose, from our perspective, of patients for clinical trials. Specifically within Firecrest, as I originally said, there's a place in my heart in terms of the first role I had within ICON. That group has done a number of different research questionnaires and facilitated that return from sites. Given that we have thousands of sites on our books at any one point in time, it's important to know what sites are experiencing. So some of the challenges, and this is fed back from investigators and site staff, is there is a lack of clinical research structure and support. There's a lack of time for administration and patient visit tasks. There's a lack of knowledge in the benefits of clinical research and experience. And also then we have conflicting priorities between research tasks, patient care and safety that permeates through all the trials that people do. So rather than try and solve world hunger in this presentation, I said I just focus on a few points of interest on the site journey, and just to give some indication of where we're focusing our efforts to try and really alleviate the burden, make it easier for sites to work with us, and to provide support in a way that's meaningful for sites in that context. And by the way, before I start this, I guess I should say none of this is rocket science. This is fundamental technology. This is stuff like removing Excel spreadsheets from the equation, removing paper from the equation, and making it easier for people to collaborate. There is one piece of rocket science in it, but I'll come back to that at the end. So we want reliable, accurate feasibility, and I mentioned this at the start, where there's no point having sites in a trial if they're not the right sites. So how do we make sure we get the right sites? That's the rocket science. I'll come back to it. We want a single point of access for people to see our services and access our services and technology. How do you train and support your site staff? Key challenge. And how do you provide continuous patient engagement activities? And when I come to it, that's not one solution. That's a plethora, that's a complete suite of methods, tools and technologies. But as I mentioned at the start, no technology is an island. And thus, partnership with sites, with stakeholders, guides the technology enablement. So, in other words, if I was in an ivory tower and I was trying to develop a piece of software, it would be absolutely useless if I didn't have your input. So this is where the engagement happens, and the journey of bringing a site through a clinical trial and the journey of how to improve clinical trials is a critical part of this as well. It has to be backed with support from experts in best practice. And the concept of networks is well understood in this group. And that's where site networks also help, peer-to-peer support. Support then from CRO to enable experience, because we would run thousands of trials. We would have 400 or 500 trials ongoing at any one time. And that's where experience across therapeutic areas will assist sites that are maybe newer to the game, newer to the concept of a particular therapeutic area or a particular type of trial. And that's just one example of where we have built a site network called Accelicare. And that's one that's internationally growing. Into some examples. This may come across as a sales presentation. It is not. It's just examples of where we've used technology in our area. So please bear that in mind. I'm not a salesperson, as you probably know. So Firecrest, I mentioned at the start, provides a single point of access to a lot of our technologies. A regulated, validated document management system, a safety letter distribution system integrated with our pharmacovigilance systems to enable us to track compound issues, etc. Site communication with sites, or site communication with ourselves, indeed, in terms of Q&A. Emails are well lost, whereas if you have an actual system that enables that Q&A, that's a much more robust and traceable and trackable environment. E-consent, and that involves patient education as well as e-signatures. Financial disclosure, some of those elements of where you want to make it easier to do that financial disclosure process, particularly for sites where you have multiple different trials going on at one point in time. Just one example. Learning management is key for large trials. Without having a learning management system that's distributed accessible to sites across the world as it is, it becomes an onerous or if not impossible task to manage the overhead associated with it. When you have an LMS in place, you see an increase in compliance, you see a reduction in cost directly with the provision of the training, and you also then see a reduction in the overheads in terms of, well, how do I know how compliant my sites are across the world when it comes to the training they need to do before they meet a patient, before they start the work, etc. And just we have examples of where this has had a specific direct impact on conversations with the FDA, as we have at the bottom of this slide. So it's just examples of where an LMS can actually provide a distinct benefit to sites, as well as the actual running of the clinical trial and how that integrates. As I mentioned, patient engagement is a key component of any technology that we want to use, because patients are related to sites, and thus it's all part of that site engagement. So, as I mentioned also, it's not a specific tool, it's a whole series and suite of tools and technologies and methods. From early stages where we look at the pre-development of protocols, how we do campaign development and how we engage with the right patients in the right place, and access points, and how we get data into our trials and how we can reuse data that exists in our EHR systems, etc. Patient education is a key component. How does your patient know that they're actually consenting to something other than through education? And how do you make it accessible? That's the key point. There's no point giving them a protocol. They won't be able to understand it, and nor could I. So something that we do here is very focused on how do you bring it to a level that makes it accessible and makes it understandable. Pre-screening, enrollment, teaching sites and giving sites visit-by-visit guides as to exactly what should happen per the protocol, but again, at a checkpoint level, to say, for this site visit, you do these 3 things. Data capture, we have patient-recorded outcomes, bring your own device. These are, as mentioned, becoming much more prevalent in our trials as well. And then at the very end, and even as we go, patient feedback is a key component. And I mentioned the site partnership. There's also partnership with patients in terms of what's your experience, what went well, what didn't go well, what can we improve on. And that combined with the site feedback helps me. My job as IT R&D is to improve the products that we provide into ICON and for all of our stakeholders across the continuum of the clinical research domain. The last example I wanted to show was the piece of rocket science, a little bit of AI for any AI enthusiasts in the room. It's not obvious, but this is something that a site will never see. This is about site feasibility and site selection. If you think about it, if you have the wrong site on the wrong trial, your engagement is lost. You have massive wastage, as I said at the start, because 30% of your sites are going to recruit no patients. So you want the right sites with the right capability, the right experience. And humans are very good at that on a small level. So if you had a list of 10 sites you wanted to engage with, a human will select the top 3, pretty much guaranteed, because they'll know the sites, they'll know the people that work in the sites, they'll know what experience they have, they'll know what they've done in the past, they know the key opinion leaders in those sites. Bring that to 1,000, 2,000, 3,000, 10,000 sites, which is a rare underestimation of what the number of sites is worldwide. That's where AI then starts to bring in additional data sets, additional computational ability at scale to be able to then help us select and rank and rate sites based on things like experience, even equipment, what therapeutic areas are specialized for particular sites, what the key opinion leaders are, what papers they've written. How do you ingest all of that unstructured data and combine it with structured data in a way that you're able to get a score ultimately to say, these are the top 10 sites you need to look at, split by geographic region, split by therapeutic areas, or particular cohorts as you need. Because that then raises the potential of getting sites that will have patients that will accelerate the clinical trial. So we have seen this being very effective from our perspective. It's not perfect, and it's always continuing, and it's always a thing that we will continue to invest in. Because if you think of the upfront piece, If we don't have the right sites, we're not going to get the right patients, therefore the trial is dead. Or it's delayed, or the outcome of the trial is questioned because you don't have enough patients, or you don't have the right diversity, or you don't have the right geographic distribution. So these are all key a key feeder into how we do what we do. So in summary, technology can help build site partnerships, but only if it's backed with people and process. You're not alone. There is support, and there are those elements where we have networks, where you have sponsors, where you have CROs that will help build the expertise, build the experience, etc., across clinical trials. The 4 areas I touched on, the last one first, which is the reliable and accurate feasibility through OneSearch as a tool, where we have an example of a single point of access to services and technology through Firecrest site portal as an example. An LMS then to enable site training and support. And then that aspect of no one size fits all for clinical trials when it comes to patient engagement. And whereas a suite of tools, methodologies and techniques to enable that, to facilitate, once you have the patients on, how do you keep them on a clinical trial? Thank you very much. That was my talk for today, and I hope it was useful.